Okay, we're now live.
All right, thank you. So welcome everyone to the afternoon question and answer session. We're very pleased to have you back again. As I said in the morning session, we're aware that the audience that we've got today, the participants, are from all over the world. The talks have been from the UK and one from New York City. And there are probably many perspectives you have that we haven't dealt with, but we'd be very interested in any questions that you have. All the others except me are mental health experts in perinatal mental health. And so if you have any questions about issues that arose from the morning sessions, we'd be very pleased if you sent those in as well. So I think I'd also like to say that we've had one comment sent in from Zimbabwe saying that there's been very little or no research in perinatal mental health and the issues discussed today in Zimbabwe, and he'd love to collaborate with anyone, any of the speakers or any of the people looking in who'd be interested in collaborating with him. So if any of you want to do any research in Zimbabwe, just let us know and we'll put you in touch. I think that would be really interesting. So as I said, that we're very aware that the research that we've talked about has been primarily done in high-income countries. So there was a bit of other things. And I don't know if any of the speakers want to just start by reflecting on cultural differences. I mean, Louise, you talked a bit about, you did give some examples about, say, for example, the effects of the earthquake in Japan and in China, and how very different the rates of depression were. I mean, I think that was quite striking. Do you have any further thoughts on that?
I don't feel that I know enough about those specific cultures to know quite why there are those differences. I think it's really interesting that in the UK, there was an assumption culturally that we would not accept a lockdown, or that is what we are told, that is one of the reasons that we did not lock down as soon as some people might have thought, was because there was a concern that culturally, unlike in Wuhan, we wouldn't accept a lockdown. I think that's really interesting, because actually we did end up accepting it, and a lot of people felt that actually maybe it should have started a bit earlier. So I think the pandemic has lots of interesting cultural potentially impacts of culture on all sorts of aspects of the pandemic, in terms of government responses, in terms of legislation, how that's differed in different cultures. And of course, cultures also interact with the context. So in low to middle income countries, I went to a very interesting talk yesterday, or virtually went, to a talk about global ethics in the time of the pandemic, and how, you know, the ethics of what high-income countries are doing and what impact that will have in the future around low to middle-income countries and their recovery from the pandemic is also something that we in high-income countries should be thinking about. And then, of course, there's the issue of working as a clinician with people from different cultural backgrounds, and how that is always something to take into account, but is maybe even more complicated in the context of people just living with the immediate household, and how that experience is going to be so different for different cultures. Some people may be used to living with the family, and other people might actually find it much more difficult to live with the family, particularly where families have decided to all lock down together when they don't normally all live together, and culturally that's not normally what you do. So I think this is definitely something we want to research when we're doing our research. We're doing an evaluation nationally of specialist community perinatal mental health services, and this was a grant that we already had just started. And then COVID happened, and unlike normal times when it can take weeks to get an amendment through to an ethics committee, suddenly everything changed, and you could get substantial amendments in 24 hours. That was fantastic, because we're now looking at experiences of different families before the pandemic and during the pandemic, the experiences of perinatal mental health problems and experiencing services that are trying to help, and how those differed across different ethnic groups, across different cultural groups, which of course isn't the same as people from different backgrounds, ethnic backgrounds, and then comparing how that differs before and during, and maybe even after the pandemic. I don't know how long the pandemic is going to go on for, and therefore the grant may finish before the pandemic.
So, Catherine, what about in New York? Are you noticing or general reflections on cultural differences?
Yes. Thank you, Vivette. I guess two thoughts, and one is Vivette and I were just commenting on a book that we both have read in common called Crazy Like Us, and I'm actually forgetting the author's name right now. Maybe it's sitting right there, and you can share it. We'll be doing a little advertising.
Ethan Waters. Ethan Waters.
That's right. I read this book several years ago, and one of the, for me, takeaways was that we need to be cautious in terms of our really constructions around diagnoses and symptoms, that they can be rather US or maybe Western centric, and that distress, that is emotional distress, can be expressed in different cultures in different ways. And there are different cultural rules, if you will, around how they can be expressed. It may be more acceptable to have somatic symptoms, stomach ache, backache, than it is to say you're depressed. So I think in considering the pandemic's mental health effects internationally, we need to be very mindful of the different ways that distress can be manifested. The other one thought, if I may, is of course, as the world rightly seems to know right now, the US is once again really dealing with our challenges around having a fair society, frankly, and we're confronting our history of racism and frankly slavery. So I think as we are working in the perinatal mental health field within a time of the pandemic, we already have this terrible background of disparities in morbidity and mortality, particularly for African-American and Latino women compared to European white and Asian, East Asian, are doing much better. So those findings have, those outcomes have emerged, as I possibly you saw in my talk. I think it was there. I've been giving a couple of different talks right now about the pandemic, but we're really seeing nearly double the rate of death in African-American Latino cultures, peoples versus the European white population that we have. And so this is
finding that in the UK as well.
Yeah, and this is, I don't know yet of evidence. We have the data to look at it in our obstetrics and gynecology department, but I would assume it's going to come out in the birth outcomes and maternal morbidity as well in relation to COVID. So this is not cultural, but they are around our differences. And I think we're going to really need to absolutely be addressing these.
Okay, thank you very much. I think what we'll do now is we have some specific questions for Michael, whose talk was a bit different, and then we'll come back and discuss the COVID and all its implications. So Michael, if I can ask you the questions that have come in for you specially. So the first is there a genetic difference between male and female? Actually, Catherine could answer this too. But is there a genetic difference between male or female neonatal brains developing mental health issues with time? I will ask Catherine because she knows about this too. Is one group more vulnerable than the other? So, Michael.
Thank you. That's a very interesting question. And one of my other key interests is in the treatment of people with neurodevelopmental disorders, which many people will know are much more common amongst males, whereas conditions such as depression and anxiety, even though there's a bias with regards to who actually goes to their physician to seek help, seems to be more common in females. And with regards to the developing neonatal brain, there's likely to be some factors that are happening in utero that may be responsible for some of these differences. In addition to the discussion today about stress, we know that in the male developing in utero, there's a surge of testosterone in around the second trimester, which one doesn't have peaking in the same way in females. And some people believe that that surge in testosterone in utero may be responsible for some of the biases that we observe later on. I think the key thing, though, to highlight is that male and female brains are more similar than they are different. And although as researchers, we're interested in looking at these differences, it's probably important to highlight that there's more similarity than disparity between the male and the female brain. But in summary, males are more vulnerable at developing neurodevelopmental disorders. There are some studies that have suggested that stress is more likely to lead to things like conduct problems in boys and more likely to lead to mood disorders in girls. But the literature is pretty mixed with regards to the effects of stress on the developing fetus. And I think we're still open to larger studies unpacking that a bit better. But I don't know whether
Catherine, because Catherine's actually looked at sex differences in utero, so that wasn't what you talked about today, but you
I fully agree. We need to emphasize what's similar, because that's far more where the bulk of what's going on. But differences, I guess the other hypothesis that I think is important to keep in mind is the idea that the male brain matures a little bit more slowly, and leading it to be potentially vulnerable to different factors. So that's one hypothesis that we keep in mind as we do this kind of work. The other is really a hypothesis, and I think with inconsistent data, but it's an interesting one, is that both the female brain and frankly the placenta, because the placenta is male or female based on the baby's sex, is somewhat more adaptive and may accommodate better to atypical influences, such as atypical levels of stress in the mother. But still really a story to be told as research is going on.
Thank you. Michael, your second question is, please expand on the definition for antenatal stress. And then it says, his findings are every anxious mother's worst nightmare. And then I could then perhaps say that follow it, because they say, is there anything that can be done to counterbalance this after birth? E.g., a supportive partner.
I think as a starting point, it's probably important to emphasize that although studies such as ours have suggested that there may be effects that stress may have on the brain during pregnancy, we don't know that these are bad things. And even, for example, findings on a more behavioral level that children exposed to prenatal stress are at increased risk of ADHD type symptoms. From an evolutionary perspective, that was a good thing. If you were in a stressful environment as a mum and you had a child that came out that was a little bit more distracted by things going on around it, it may be more likely to survive. And translating that into life in the 21st century, people that have these ADHD symptoms are more likely to be creative, to have ideas that are perhaps a bit more outside the box. They might be less good at being your typical accountant, but as I say, they might be better at these more creative things. So just because we see differences doesn't necessarily mean that that's a bad thing. And I think that's important to bear in mind. Clearly with the one of the studies that I was showing today, the suggestion that prenatal depression may lead to differences in the way that the baby is then responding to certain sounds may again have some relevance to these attentional biases. But again, I think these things need to be thought about in context and not necessarily be conceived of as being a bad thing. So I hope that the take-home message is not that antenatal stress is bad, but it may be associated with some differences, and these differences may be positive and or negative.
Yeah, I'm not sure I completely agree with this. I mean, I completely agree with the evolutionary reason, but I think in our modern society, it's often not very hard. It depends on what your environment is. If you're in a very physically dangerous environment, then being extra vigilant and more anxious. or having conduct disorder being for the males being very reactive and aggressive might be protective. But I don't think it's often protective in a more urban, advanced environment. So I agree with the reason, but I do think we want to appreciate neurodiversity and think people often have special qualities that go with the ones that are harmful. But I wouldn't put it all as equivalent. Louise, you're nodding. I mean, but Catherine, you come in first.
Oh, no, Louise, go first if you have
No, okay.
Yeah.
Okay, well, Catherine then. And then we'll go on to something else.
Yeah, no, I mean, I resonate with both of you. I think that one way I often emphasize it is the match between the prenatal and the postnatal environment. What was the baby being shaped for in utero, and what then do they find postnatally? And how is that match? But I think we all, particularly those of us working in this prenatal area, have to remember that development is long. I like to think I'm still developing, hopefully still some neurogenesis happening. And that's always if you will, a plastic process. So there's always plasticity. We can always have different exposures and change to meet those exposures, hopefully in more optimal ways. So that's often what I tell when I'm working with pregnant and postpartum women, that there's continued and ongoing opportunity to enhance your baby's development and getting the support you need to do so.
And in terms of what can be done later, I mean, we have evidence that mothers that had secure attachment to their babies, it really buffered against the effects of prenatal stress based on cognitive development. Yeah. So that, I mean, the baby's brain isn't, though it's affected by what happens in the womb, it's still affected by what happens postnatal.
Yeah.
So things could go better or worse, but it's not all over at birth by a very long way.
Right.
It's fascinating what you find the effects of birth, but that's not the end of the story.
And I think the other thing, Vivette, is some people ask, well, what's the point of these brain imaging studies? They're very interesting. They show us differences perhaps that are there. And the real reason, of course, why we are doing these sorts of studies is to see if there are brain differences that are there very early on that we can then track back to and identify those children and to devise treatments that perhaps can be delivered to make the sort of positive changes that we're talking about. But I suppose I as somebody who deals with a lot of neuroatypical adults, I'm also very keen to emphasize the positive aspects of these conditions and not to just see them as disorders that need to be treated. But clearly they do have negative consequences associated with them. And it's those aspects that if we can pick up early on, so we can scan a neonate and see a brain that's more likely to develop into an autism spectrum condition or more likely to develop depression later, those may be children that, or neonates or infants that we can target much earlier on than we're able to do so at the moment.
And again, from a developmental psychopathology model, development is like a branch on a tree. So you just have all sorts of opportunities to be shaping that brain branch into, directions that are a better fit with the environment and can lead to a more rewarding life, hopefully for them. I also think from Louise's standpoint and mine that your kind of work really supports the need for perinatal mental health. Because if we were helping women during pregnancy and these families that are starting, we hopefully wouldn't need so much intervention and treatment later on for children.
Okay, thank you, Michael. So now a question for both Louise and Catherine. Has there been any research, or is any research happening that investigates the effects of COVID-19 on partners' mental health and well-being, especially as partners are usually not allowed to accompany women to their appointments delivery? So Louise, do you want to go first?
Yeah, sure. So like I mentioned, we are going to be looking at partners' experiences of perinatal mental health service care for the whole family. In terms of a representative study of partners' mental health, I am not aware of one, but I bet you there is one. And there is a register that I mentioned in my talk of COVID-19 and mental health studies. So this is a UK-wide initiative so that everybody knows what everybody else is doing, because there's the most incredible explosion of of studies at the moment on mental health and COVID-19. And some people are worrying that maybe there's been too much of a rush to do studies without thinking them through carefully and actually doing them in the most robust methodological way. And clearly there is a danger of that. But there are also some really fantastic studies going on. And there are, of course, some studies which will be looking at the whole population or a particular population that will have a lot of fathers there. And it may not be the primary research question, but there could be some really great opportunities for secondary analyses looking at fathers. So thank you for the idea.
Catherine?
Yeah, I would echo that and say that I described our COPE study, which similar to what Louise just said, is sort of rushed to get into place. So that's somewhat problematic, but it is across the US and then has some international collaborators. And I will say, in being rushed, there was not a big emphasis on partners. And this is an idea to really, now we have time to do this. I think another area where partners are becoming important is the partners of frontline providers or any kind of healthcare provider. And so we've been doing some work with those partners. And I do hope that that will become a research area, because that's a particularly difficult position to be very concerned for the welfare of your partner being on the front lines for then what they are. In fact, the New York Times just did a piece on this yesterday. The fears of people returning home, are they going to infect their families? And then what I've heard from some providers, this is more partners rather, this is more anecdotal, but heard it from a couple of people, starting to feel that their work hardly mattered compared to being with someone who is literally saving lives right now, or part of the team that is taking their own health at risk to help other people. So a lot to, I think, understand there and think about how to make better interventions.
There's another question for you too. What might be the effect of COVID-19 across countries, focusing potentially on the effect of different countries or even state policies on perinatal mental health? That's a pretty big question, but you're nodding, Catherine, do you want to go first? I
would just say that I hope people, other countries learn from what we went through in New York City. The literature out of China, I haven't done an exhaustive review, but was not as focused on the OB experiences as our hospital has tried to be, and I think a lot of others now are. So the OB experience for providers and obviously for patients and their partners, their families. So I hope people can learn from us. The chair of our department and our team, they've been publishing a lot. There are more papers coming out, also in terms of neonatal care, as I tried to suggest. That paper is just accepted into JAMA Peds. So I hope there can be learning and not only from what's in the literature, but really consultation with people in our department. I think we'd be very open to sharing lessons learned and also hearing from others what they're experiencing. We have to really communicate rapidly, particularly if there's a resurgence.
Louise?
Yeah, I mean, I think that one of the areas that people aren't talking about as much, but will vary hugely across countries, is social protection policies, which I briefly alluded to, because I think COVID-19 is really going to exacerbate structural inequalities in mental health. And obviously that's particularly important, we all feel, around perinatal mental health. So, you know, what's going to happen to people who've lost their jobs and are even more financially squeezed and stressed? What's going to happen for those families where family violence started, where actually it hadn't been a problem before, but anecdotally we're hearing about relationships actually where there's new onset, much more new onset domestic violence, and is that going to continue, and how will the state respond to that? Will there be funding for the third sector services, or is that going to continue to be a real issue? And again, I think because so many billions of pounds have been spent on addressing some of the issues around lockdown, there's going to be huge reluctance among governments to advocate for social protection policies, particularly for right-wing governments.
I'm just thinking about cultural differences, and you both talked about domestic violence. I mean, there are huge cultural differences, aren't there, in attitudes to domestic violence? And I wondered if you'd come across that. I mean, Jane Fisher had a paper where she was saying that over 90% of women in Afghanistan thought it was acceptable for men to beat their wives, whereas in other countries, like in I think it was Argentina, it was completely unacceptable. So there are huge cultural differences in attitude to it, apart from dealing with it.
Yeah, well, talking of Jane Fisher, she's done this fantastic study around the Nepalese earthquake. And she found a really important finding that it wasn't the impact in the medium to longer term wasn't actually about the earthquake itself in perinatal mental health. It was actually the impact of things like intimate partner violence. That had a much bigger effect on subsequent perinatal mental health than did the earthquake itself. The other issue that impacted on perinatal mental health was things like not having a house. So, again, major stressors around insecurity of different types. So I think structural insecurities, inequalities, and particularly family violence, because it's so endemic, are going to be a major issue after or during COVID-19. And of course, we know that also places like Ethiopia, for example, where it's considered normal, acceptable to beat your wife, despite actually really fantastic legislation in Ethiopia against it, but nevertheless, the attitudes haven't caught up with the legislation. They've had a very Chinese style lockdown. Charlotte Hanlon, who some of you may know, who works in Ethiopia, was immediately quarantined on her return back to Ethiopia. Very, very careful, very Chinese type, rigorous, very unlike the UK. And that's going to be really important in thinking about the impact of family violence in these families where there's, they've lost they're not going to be able to access money, they're not going to be able to access food anymore. I mean, there's sort of the level of insecurity is just huge, and that's going to impact on family violence and of course, therefore, on perinatal mental health.
Just add once, go ahead, yes.
Just to add one thing, and I feel like I'm being the devil's advocate for the positive slant on things today, but despite being, as I mentioned earlier, somebody who spent 10 days in hospital with COVID-19, I have, and I think like many people, also seen some of the positive aspects of families being basically forced to be together for a period of time that I've certainly never spent with my family. And I think lots of other working people haven't had the opportunity to spend with theirs. And I'd like to think that some of the research that's done is not going to just look at the negative effects, but also perhaps focus on some of the positive effects that we've seen with some families being held together at a time when they wouldn't have otherwise been.
I think, and along that, there's going to be a huge resistance. I hear this a lot from my patients with young children, huge resistance to going back to business as usual with parents away from their children, 8, 10, 14 hours a day, and only together on the weekend in very, very pressured time. I think there's just, and of course, because the US has absolutely no childcare policies and no support for working women and men and to take care of children once they're born. We just really, and hopefully that will be our next challenge we really need to accomplish. So I agree with you, a lot of positive, but just to be negative, on the negative side, again, the New York Times has really been reporting a lot on the effects of COVID. And I think the report for child abuse hotline is down by 50%. And I think the domestic violence line is comparable. So and maybe some of that is good because there's actually less of it going on. Of course, the huge concern is there's just less surveillance and people aren't being seen. And so these calls are not being made, or women are, not happening.
Another question is, I'd like to get your comments of if there's any special program for perinatal women living with HIV during this time of COVID-19, considering they're more vulnerable to depressive symptoms. Do any of you know of anything?
Not offhand.
It's a good question, and we
I think
have
it's a
people
good
from
question.
Kenya. I don't know.
Yeah.
I mean, we have several from Africa actually, and I don't know where this question comes from, but it's a very, very good question, but we don't have any answers. Is that right?
Not offhand.
Do the discussants have input regarding whether the stress on care providers, obstetrics, gynecologists, midwives, nurses, etc., working during this time may have influenced how they managed peripartum women, e.g. less likely to let a woman labour without intervention, more likely to use NICU to monitor baby, etc.?
I don't know of any data on this. I can only speak anecdotally. I think I referenced
Good
this.
questions, aren't they?
Yeah, it is a good question.
Yes.
I mean, anecdotally, people are absolutely worn out, but our department, what I've seen is there's been a tremendous commitment to getting providers and staff the support they need. We did have a physician suicide in the ER department during the pandemic.
It was famous. Yeah.
Yeah, and that is, you know, absolutely galvanize people that we have to be mindful of how we are doing as well. And of course, also because it has downstream effects on patients. So we have this, it was daily, it's now 3 times a week call for the entire department, providers, staff, everybody. Which obviously that's not the moment where people are coming forward to say that they're struggling, but it builds a sense of community, and the resources that are available to people are underscored. So I think this is really being looked at and very mindful of people who are needing a break for them, and also then for the care of their patients. It's a great question.
During the COVID pandemic, did you notice an increase of a wish for home births in order to avoid getting infected in hospitals? Was this also seen in prenatal visit?
Yeah, absolutely. That was also a big concern with particularly when there was a no visitor policy, which was only about 2 weeks for us. But in anticipation of that, a lot of women started to choose home births, and this was a concern because many of these women have complicated pregnancies, and so really do need to be in hospital. There have also been women choosing to give birth outside of New York City when we were at the height of the pandemic. They just didn't want to be at any institution that was a hotspot. I will say, however, that the messaging that came out of the governor's office was you can go to a birthing center and it will be COVID-free. And that is just illogical. We have to accept that nothing is COVID-free right now. We work very hard to make environments COVID safe. And so that has to be the goal. And you want to think about institutions as now we feel like we have had a lot of experience of how to make an environment COVID safe. So we are really confident about having women and seeing women very much back up at our typical numbers of how many births we're doing a day.
So another question, I don't think I've asked this. There's sort of 2 BAME-related questions, Black and ethnic minority. Are there any added services being done or proposed that are aimed at supporting women from BAME communities who might be facing the added stress of the current protests happening in the US and the UK? And then another question was, what are the hypotheses about why BAME women do worse?
Why which women do worse, sorry?
The Black and ethnic minorities. Do you call it BAME? We call it BAME here.
No, we don't have that acronym.
You don't have that word. Okay, well,
No.
maybe a lot of the audience don't. Or Black and ethnic minorities. So why are they doing worse, and what are the extra support services? Louise, do you want to go first, and then Catherine?
Okay, well, sort of answering the second question first, about the hypotheses about why there is this excess. I mean, it was interesting, the news yesterday, I think it was yesterday or the day before, about the Public Health England report having missed out the section on potential mechanisms to explain the excess. And this was written by a professor who'd actually worked in the CDC in the States. He's got a huge amount of public health experience, was Black himself, and apparently it was talking about structural reasons, you know, racism basically, not only about poverty, which clearly is an issue, but also about some of the other stresses that people are experiencing every day of their lives. And, you know, it was a section, I think, where it was called a community engagement section, and it was inviting comments from different community groups. So different people from the communities were talking about the racism that they'd experienced, and clearly that's the section that we need to see. And it does make sense in the light of what people are really talking about now around Black Lives Matter, and about the microaggressions as well as the macro aggressions, and us having to really think carefully about what we as white people should be learning, you know, about some of the assumptions that we've thought about just walking past statues that I've never thought about. Another interesting thing.
I don't have any statues left soon, I think.
Yes, I mean, the other thing is that it was a very interesting point raised by somebody at an online event that I was at a few days ago, saying that, you know, there are statues commemorating the Holocaust, and yet there aren't major statues in London commemorating slavery. And, you know, both are clearly important. And why is it that that's been so overlooked? You know, what is it about our colonial past that makes us...
We're nearly out of time. I mean, I agree. Can we have Catherine, would you like to finish up? Because we've got to finish in a minute.
Just really to echo all that Louise is saying, and we are trying to work out having groups, support groups that would specifically be for African-American women in pregnancy and postpartum, and figuring out who would be the right facilitators for that. I am not the right facilitator, or certainly I alone. I heard had a chilling session with a patient yesterday in terms of really hearing the depth of this. And I think we all need to listen better. She's an African-American woman, and she was told by her OB providers, my colleagues, that her baby is very, very small, and they're a little worried. She's gained the correct amount of weight. The provider had called me before the session and said, I want you to know this may be intrauterine growth retardation, and I just want you to be aware of this. What the patient heard was, I've gained enough weight. How can this be happening? I think they're telling me the baby is small because maybe the C-section would be convenient for them. And that would be, and this was chilling to me. I gather this is not uncommon. We're not hearing enough, because she's a very well-informed woman. She knows about the disparities in birth outcomes for babies and mothers for African-American women, and the trust is not there. So, and the communication is lacking.
We'll have to think about it more. Michael, do you want to just finish up with something optimistic?
That sounds great.
Michael?
Maybe his earbuds went out.
Michael, can you hear us? We can't. Well, Michael can't finish up with anything optimistic, but I'll just say this is the end of the day. I mean, I really think the talks have been excellent, and I hope that all you who've been watching have enjoyed it. We've really enjoyed having participants from all over the world, and I wish you all well. Thank you. Goodbye.
Thanks so much, Vivette. And lovely to see you.
Yes.